Uh, um, All right. Good afternoon. As everyone is signing in, as you're logging in, please sign into the chat so that we can know who's here. That is always helpful. And thank you for your time today. We have a wealth of some great information, two excellent speakers that are going to facilitate an excellent dialogue. We do want to keep this as interactive as possible because as our key leaders and experts, boots on the ground, as well as prevention specialists and recovery specialists and treatment individuals, and we have a range of talent in this audience, we want you to be engaged participants, and so we're going to keep this as interactive as possible. We are the Ward 7 and 8 DC Prevention Center. We periodically host these key leader lunch and learns, and we are doing this particular lunch and learn as part of Prevention Month, which was October, but it was better for us to schedule this meeting today. There was a lot going on in October, but this is still part of us celebrating National Prevention Month, which was October, to just heighten awareness on some key issues. And as many of you all know, mixed drug use is a huge problem across the country, and it's a really significant problem here in DC, especially when you attach it to our opioid crisis. Some of you may not be aware because you don't do this on a regular basis, but DC has one of the highest opioid fatal and non-fatal rates in the country. We've consistently had that since we've been tracking it since 2018, and unfortunately, in recent years, the numbers have gone up. We lost over 500 people last year. So that's more than double the number of homicides. And in the last few years, the number has been trending younger. So teenagers and young adults have been, the use has been increasing. The numbers might be small, but for those of us that do prevention and harm reduction education, any increase is bad. And so we've been monitoring this trend. This year, it looks like we're on point for the numbers to be going down somewhat, but they're still too high. Because as of June, we still had 198 fatal overdoses. And so that's about halfway through the year. So if that trend continues, that means we're still going to have close to 400 deaths. Better than 500, but still too many. But in addition to the deaths, what also is going on, again, is this mixed drug use, and especially these various synthetics. Some of them are opioids, some of them are not opioids. And so why is that important? That's important because if the synthetics are not opioids, then the Narcan is not going to help in terms of bringing people back. But we still want people to get the Narcan because since they're mixing the opioids with synthetics that are not opioids, we still want them to get the Narcan, but just be aware because of these non-opioid synthetics, the effectiveness of the Narcan is the issue that we should be concerned about. So I don't want to steal the thunder of our speakers. I just wanted to give that as a quick backdrop of why I thought it was important for us to have this emerging drug trends discussion today. We're very fortunate to have Josh Eschricht, who will be presenting the national and regional data. And then we have Sine Parikh, who is with the DC Forensics Lab, that will be presenting the local DC data. We're very fortunate to get the full perspective. So with that, Josh, I'm gonna hand it over to you, dear.
All right. Thanks, Ross. Hi, everyone. Thanks for being with us here today. Just give me a second while I pull up the slides. I can just tell you a little bit about me. I've been doing sort of prevention related training and technical assistance for over 12 years now. I did this content plus a little bit more at the NPN conference in Arizona. this past August, and Roz saw it and thought it was a good presentation, asked me to come back to speak with you all today. So I'm happy to be here. I've lived in and around DC since 2009, actually. Right now I live over in Arlington. And even though a lot of the work I do is more national or regional focused. I do sometimes do DC specific work as well. I've worked on and off with DBH a bunch of times over the years, more often on the treatment side. I was one of actually the evaluators for the SYT program when they were implementing ACRA, if you remember that from a few years ago. And I'm with a company called Carnivale Associates, which still regularly does work with DBH. So if you ever see that name, you can know that they're some of my colleagues. Um, so the overall learning objectives that I put together for today, I'm really covering the first three about sort of just first of all recognizing why it's important that we do look into emerging trend data and make sure that we're incorporating it into our effort, planning efforts for figuring out the work we want to do. Then we're going to also identify what are the latest trends, as well as describe the scope and impacts of them. And then the fourth objective, which I think will be more what Sneha's talking about, even though this is just my slides are up right now, are more about like the implications and impact of these trends on the District of Columbia. As Roz said, definitely want this to be informal and interactive. So, interrupt at any time if you have any questions or anything you want to ask about. And actually on that note, I should find a way to pull up the chat because I don't actually see it right now. And I would like to, in case people
I
put
can
anything in
help
the
you with
chat.
that, Josh.
Okay,
I
great.
can help you with
Thanks.
that.
Okay,
Yeah, I'll
awesome.
help you.
Okay, thank you. And I think I just got it up as well on another screen, but yeah, definitely appreciate the help. All right, so that first learning objective, as I mentioned, just briefly before we really dive into the data and what the trends are, which I think what everyone's most interested here in is just why we care about this. And basically, we care about emerging trends regardless of what they are, because if we're able to collect data on them and analyze that data and understand it, it lets us answer some of the key questions that we would like answers to when we're trying to do any sort of planning efforts, whether we're doing something formal like SAMHSA's strategic prevention framework or just a little bit more informal strategic planning. We want to know things like, are there specific substances that are becoming more commonly used in our community? Because if there are, that means maybe we need to maybe our existing prevention work isn't going to be as relevant to it. If we want to be talking about like perceptions of harm, we need to be talking about the specific substances that people are using. Or if opioids are continue to grow, we might want to expanding the harm reduction. Conversely, right, if like methamphetamine use is growing, Narcan isn't as relevant, so we need to be doing other work. So we want to know if there are different specific substances that are becoming more commonly used. We also want to know, regardless of what the substances are, is substance use disproportionately increasing among any of the various populations? Because that's emerging trend data as well. We want to know, is use specifically expanding among, Hispanic youth or older white women or older African American men or whoever the different populations are. We want to know if there's a disproportionate, increase in use, because again, that can help us better target the services we're trying to provide. Like related to that, we also want to know if the consequences of substance use are becoming more severe, because even if use itself isn't increasing, if the consequences are among certain populations, that might also indicate a need to change services in some way. So, for instance, one of the substances I'll be talking about today, nitazenes, are an opioid, but they are far more powerful than most other opioids. And so even if the overall number of people using substances is about the same, if more of them are starting to use nitazenes, that might mean the consequences of that use is getting a lot worse. And then sort of related to emerging trends, we also want the trends themselves. We want to know more about the risk factors leading to those changes. Have there been increases in availability, decreases in perceptions of harm, changes around legalization or enforcement of laws? Because that can also, help us learn more about the mechanisms behind the changes and sort of, again, help us learn more about what are the things we could be doing to address them. So that's why, we want to stay on top of emerging trend data. We definitely don't want to be playing whack-a-mole, just like focusing on the latest substances and sort of ignoring the root causes of substance use. That's absolutely not what we want to do, but we do want to still know what are the latest emerging trends so that we can better answer these questions. And if we have these answers, it can impact the actual work in a lot of different ways. It might lead to us deciding that we have new priorities we need to address, or confirm that our existing priorities are the ones that we want to keep working on. It can also lead us to figuring out that we need to not bring in new partners that we haven't been working with before. For instance, another one of the substances I'll be talking about is xylazine, which is legitimately used in veterinary medicine, which means to prevent diversion. Maybe there's some sort of connection we'd want to do with local veterinarians. Maybe not. It depends on the actual planning, but we want to at least consider it. It can also lead to us, as I've mentioned, determining if we want to sort of change our strategic plans in some way. And that can lead to us potentially changing our actual strategies or adjusting them in some way, or just maintaining what we're doing. Because sometimes what we're currently doing, is the best thing to be doing, but it's important that we know that, and we want to make sure we have as much data as we can. So again, that's why we care about these things. And the last thing I'll say on this is that this slide here shows sort of a very simplified model of the growth of an epidemic over 3 stages. And this was developed over the course in response to the opioid epidemic, so showing it, but it's relevant to any sort of substance use epidemic. Where in stage 1, it's mostly people initiating use, experimenting with use, but there's not actually that many people using the substance yet. But over time, you get into stage 2, where more and more people are regularly using the substance. And then in stage 3, you start to have more and more people with full substance use disorders. Sometimes even prevalence rates go down overall, but more people who are still using the substances do have substance use disorders. And we do see that, with the opioid epidemic, where the most number of people misusing opioids, and it was primarily prescription opioids, was actually in like 2010, 2011. But the number of people with opioid use disorders and the number of, opioid overdose deaths is far higher now than it was in 2010. Even though that's when the largest number of people who just misusing prescription opioids was occurring. And so the idea is, right, and I think probably everyone knows this, the earlier that prevention works or gets involved, the greater the impact we can have. Ideally, we do start providing services when it's still just in that stage 1, and we're not waiting until we are in stage 3. And so, some of the substances I'll be talking about today, we don't have much data on them yet, to be honest. And the data that is there suggests that there's not a ton of use yet, but it doesn't mean we want to ignore it. It maybe means we don't put a ton of focus on them yet, but we want to be staying on top of them so that we can implement services early on, rather than waiting until it does become, a full-blown epidemic. So with that sort of background out of the way, want to just sort of dive into things then. Unless anyone has any questions about that. All right. And if anyone does have any questions in the chat, please. Okay. So I have, as I mentioned, sort of several different substances I want to talk about today. We're going to go through each one in turn. As I said, a lot of what I'm going to be talking about is more what we see nationally and regionally, as well as just talking about what the substance itself is, some background on it. And then, Sneh will be, I gather, doing more of the DC specific data that the Department of Forensic Sciences has been able to obtain. So the first substance I have here is xylazine. It's the one that folks might be the most familiar with. A lot of times when I do this presentation or similar ones, it is because it has been talked about a fair bit over the past couple of years. If you're not familiar with it, though, it is a veterinary anesthetic that's not approved for human use, but is approved for animal medicine. It's a sedative. It's not an opioid, but so there is that issue, right, that Ross was talking about, where if someone has a xylazine overdose, Narcan won't reverse it. But of course, you want to administer Narcan anyway, because probably opioids are involved. Because xylazine is generally used in conjunction with opioids. Chemically, when you combine the two, it extends the length and effects of the opioids, the sort of positive euphoric effects that people are misusing them for. And so a lot of times they are used in conjunction with each other. Some people do misuse xylazine on its own. We don't really have data on how often that occurs, but it does seem like it's a lot less common than it being used in conjunction with opioids. And a lot of times that combined use isn't even something people know about. They think they are just purchasing, heroin or fentanyl or whatever the opioid is, but it turns out there's xylazine in it as well. The thing about xylazine as well is it's not a federally controlled substance. There are a growing number of states that have, issued state laws making it a controlled substance, but since it's not federally controlled, it's actually pretty easy to purchase, especially online, just in bulk. And that availability and sort of its cheapness as well is one of the reasons why producers of illicit opioids have been more and more frequently combining it with the illicit opioids. Use of xylazine has been slowly spreading in the mainland United States since about 2006. We first saw it show up at all in Puerto Rico in about the year 2000. And sort of the initial and actually still epicenter of use of xylazine is Philadelphia. And use has been spreading sort of outwards. I have a map in a couple slides that sort of illustrates that the closer you are to Philly, the greater the rates of use and overdoses are. And we do know that for the past couple years now, xylazine use has been spreading southward through Maryland, and certainly is in DC as well. And it is in fact nationwide now, but our region is still the epicenter of xylazine use. And we care about xylazine because it does increase the risk of an opioid overdose if it's being used in conjunction with overdoses. We don't have complete data on how many people are just using xylazine. It's not something that's asked in the various national surveys, and a lot of forensic labs don't comprehensively test for xylazine use, if they get like samples seized from law enforcement or things like that. We do have overdose data, which is what I have on this slide, but even the overdose data isn't comprehensive because not necessarily every coroner or medical examiner is testing for it either. So we know that there were at least 3,400 fatal overdoses that involve xylazine nationwide in 2021, but we don't know how many more than that. There were probably not that many more, but it was at least that amount. And sort of illustrating what I was mentioning about Philadelphia, just over a third of every fatal overdose in Philadelphia in 2021 did involve xylazine. So that just sort of illustrates just how much that scope has grown. So a separate data point is that over this 2.5 year period from January 2019 through June 2022, about 9% of fatal fentanyl overdoses involve xylazine, so just under 1 in 10, which sort of illustrates the fact that xylazine is most commonly used with illicit opioids, especially fentanyl. So the inverse of this statistic is that 99% of xylazine fatal overdoses also involve fentanyl. So they very much go hand in hand. I've done a presentation all about xylazine before with a wound care nurse who works in Maryland. And the way he phrased it is that chemically, xylazine and fentanyl are like chocolate and peanut butter. Like they really, but obviously very dangerous. That's not like a positive association we're making. But the point is they very much increase the effects of each other, which is one of the reasons why xylazine is so dangerous. Another reason why xylazine is so dangerous is that, what has many different negative health effects, just like a lot of, illicit substances have, they're dangerous chemicals that can do all sorts of things. But something somewhat unique about xylazine are the necrotizing wounds that they can cause on people. And those wounds aren't just at injection sites, assuming the xylazine is injected. They're not just in the mouth if people are, ingesting the xylazine. They can show up pretty much anywhere. We don't entirely know what causes them to show up, but they can grow very dramatically. They can even lead to the need for amputations if they're not properly treated. A study from 2011 in Puerto Rico, where again xylazine use was already becoming more common, found that about 40% of people who use xylazine did develop those necrotizing wounds, and is why sort of harm reduction around xylazine is so very important as well. That that wound care nurse I mentioned, his main thing was just working in the community trying to treat people's xylazine related wounds, because they are potentially so dangerous. So this slide here is that 2021 data. It's showing the rate of overdoses per 100,000 people, which is the way that you sort of compare different population groups. And you can see, right, Region 3, which includes the district, as well as West Virginia, Virginia, Pennsylvania, Maryland, and Delaware, has by quite a high margin the highest rate of xylazine-related overdoses. Now that 4.0 number is, far lower than the fentanyl overdose rate, which for 2021 I believe was in the high 20s. But it does show sort of the impact that's having, and also, right, you can see what I mentioned. So if it's spreading outwards, that the regions bordering our region have the next highest rates, even though generally they're a fair bit lower. And then you start going west, and like, okay, xylazine is there, but it's a lot lower numbers. And I also recognize, right, that 2021 is 3 years ago. Unfortunately, we don't have more recent overdose data than that, at least not comprehensively. That's the issue with the testing not always occurring. But we do have more recent data from the DEA on their seizures, seizure data, which does show sort of how xylazine has continued to spread. We do see that our region, and actually especially Pennsylvania, is still that epicenter. But this chart really does illustrate how it is becoming more of a national problem, and also obviously still a district problem as well, especially as use continues to spread through Maryland towards us. And that's sort of that xylazine. A lot more could be said about it. As I said, I've done a whole presentation just about xylazine. But since we have sort of 5 substances, I think it's 5 that I'm going to cover today, I'm going to move on to the next one. But again, if you have any questions, please do put them in the chat.
Hey, John.
Yeah.
Real quick, because I know we're on a time frame. Real quick, I just want everybody to know, because I'm a detailed person, so I took a deeper dive after your excellent presentation about why Philly, and you mentioned Puerto Rico. So in case people wonder why Philly and the zombie town, if you want to Google it on YouTube, just look up Philly zombie town. You'll see a lot of videos of what's going on up there. It's very bad, sad. Is because people in Puerto Rico has a lot of horses. People in Puerto Rico is where it really did start in this area of using xylazine. They couldn't treat them in Puerto Rico, and a lot of them were sent to Philadelphia for treatment. That's how they got to Philly. Just in case people were curious, because I was. Why Philly? That's why. A lot of people from Puerto Rico were sent to Philly for treatment, and then they ended up, in the streets of Philly. Just wanted to share that.
Thanks, Roz. Yep, no, it's true. And one of the other places actually where people also were sent were Connecticut. Not as many, but some. And so Connecticut was another early epicenter, but Philly absolutely is the core of it. All right, so so Man and I do see a question. How's the substance so readily available if it's for animal use? It's because you can just buy it online. Like, you don't need to provide a veterinary license number because it's not a controlled substance. I wish I had my own anecdotes, but again, that nurse that I did a presentation on xylazine on as well, he said that a few years ago, he looked online and he could buy a 50-gallon drum of xylazine for like under $100. It is produced a lot of times overseas, in China, but I think there's other manufacturers as well. And you can just buy it because it's not a controlled substance. And so if someone is producing or distributing illegal drugs and wants to cut xylazine into it, they can just purchase it online, mix it in. And that's why there has been an ongoing debate in Congress about making it a controlled substance. I know there was a bill that was introduced last spring, but it hasn't been passed, probably just because not many bills pass Congress anymore. I don't know if it has anything specific to do with xylazine, but that's why it is so readily available right now. So nitazines, just switching gears to the next substance, they are an opioid. They're a synthetic opioid that was actually originally created all the way back in the 1950s, but was basically ignored until just a few years ago. And as I'll talk about in a couple slides, the reason they came back is because they are incredibly potent. Nitazines are a controlled substance, but a lot of the laws around controlled substances are the specific, what's actually controlled is a specific chemical makeup, a specific molecular structure, and nitazines you can change one or two elements of the chemical of the molecular structure pretty easily and still have the same effect. And all of a sudden, it's not a controlled substance anymore, unless the laws are written more broadly, which there have been efforts to try to do. But because of that, there's at least 13 types of nitazines that we know of out there. The most common is isonitazine, which is its street name is isos. So if you ever hear that, nitazine is what it's being talked about. A lot of times it is just being mixed into heroin or fentanyl rather than being sold on its own. It also sometimes is being pressed into counterfeit pills that are being sold as oxycodone. And so as far as we can tell, most people using nitazines are using them unintentionally, not seeking them out on purpose. I think probably a lot of people don't even know about them specifically yet. But because they are synthetic opioids, they do have all the same impacts of other opioids, which is why people will misuse them. And they can be available, in all the different forms that opioids exist in. They are an opioid. They were first identified pretty recently, as I mentioned, in actually 2019. Interestingly, they showed up both in Europe and the US at the same time, and originally in the Midwest, but they've spread since then. We don't really have data on nitazine use or overdoses. They're not something that's very commonly tested for at all. We do know that since 2019, there's been at least 4,300 law enforcement drug seizures that did have nitazines because those seizures were tested. But we don't know what the delta is there. We don't know exactly how common they are showing up. But when they did show up, most commonly, again, as I mentioned, they're found alongside illicit opioids or sometimes benzodiazepines. There was a study, and I think it's just because of where the researchers were located, of wastewater in Washington and Illinois. They found nitazine in the wastewater, which does indicate that nitazines are being used. Again, it's not helpful for letting us know how commonly they're being used, but it lets us know that, okay, they are being used. And as I mentioned, they oftentimes are Schedule I substances in the US and are restricted by other countries as well. They're not something that's as readily available as something like xylazine. So they're just the latest opioid. And then the question is, well, why do we care about nitazines then if they're just another opioid? Well, we care about them because they're up to 43 times stronger than fentanyl, which can let that sink in for a second, right?
Right.
Because
let that sink in for a long second. 43 times.
Yeah. Because a lot of times we measure the strength of opioids around their equivalent amount of morphine, the morphine equivalent dosage. And so that's where we get stuff like, we find out that, all right, heroin is twice as strong as morphine. Fentanyl is up to 50 times stronger than heroin, which means up to 100 times stronger than morphine. If nitazines are up to 43 times more potent than fentanyl, that means they're up to 4,300 times more potent than morphine. Like it's hard to even wrap our minds around just how powerful nitazines are. And because they are so incredibly potent, they have just an extreme risk of overdose occurring, even if there's just a very small amount of nitazine. Most commonly when nitazines are appearing, we think that they're being cut into illicit opioids so that far less fentanyl or heroin needs to be in the mix. But that's a dangerous game to play with nitazines being this strong. So if they do become more widely spread, if use becomes more widely occurs, it does prevent an enormous risk. The good news is, since they are an opioid, theoretically Narcan will reverse it. But because of their potency, it's almost certain that multiple doses of Narcan would be needed, with a single one not being enough. And a lot of those Narcan kits only have one or maybe two doses in them, which may or may not be enough if there's enough nitazine in the sample, not the sample, in the amount being in what's being used. And so it is something that there needs to be a lot of education around, especially if use does grow around like how harm reduction can respond to it. We know that there was a study that found that there's been at least 200 overdose deaths in Europe and North America so far related to nitazines, which isn't a huge number, but I will say it's almost certainly a dramatic undercount, because the state of Tennessee actually did a study themselves, and they found that in 2020 they had no nitazine related deaths. In 2021 they had 10, and in 2022 they had 43. First of all, that's a pretty bad trend, going from 0 to 43 in just 2 years. But also, that's just a single state, right? So if 43 were in Tennessee, then in all likelihood there were way more than just 200 in the United States. And in fact, that 200 number is the U.S., Canada, and Europe. So the point is, we don't have great data yet, but deaths are occurring. The wastewater samples that I mentioned show that use is occurring. So it's something that we want to make sure there's more testing around, and definitely want to get that education around Narcan, and so the potential need for multiple doses out there around. So yeah, that's nitazines. Again, I could say a bit more, but in the interest of time, I'll move on unless folks have any questions, or Roz, if there's anything you wanted to add.
Well, you may have mentioned this. Is there any legitimate reason to use a nitazine, like a prescribed reason?
No. So nitazines are Schedule 1, which means that they are considered to have no legitimate medical use. And in fact, back in the 1950s, we didn't have the current schedule yet. That wasn't created until 1973. But basically, they were made illegal from the very beginning. Like, some researchers in a lab created them, and they realized, oh, this is so much stronger than we ever need an opioid to be. So no, nitazines do not have any legitimate uses.
Any legitimate purpose. Okay. Just checking. Thank you.
So again, it's something we have to keep an eye on. It's not to say that nitazines are everywhere, but because of the risks involved with them, we really want to be keeping track of them, and very much want to ensure that testing, is occurring, so that we can learn if they're becoming more prevalent.
Okay. So do you purchase nitazines? How do you purchase them off the web as well as you do a lot of the other drugs?
So no, I mean, a lot of times I think they're being just sort of made by the same, criminal organizations that are making fentanyl, or producing heroin, and then just sort of mixing it in. I imagine there are ways to purchase it, like on the dark web. I don't really know a ton about that, but there's no legitimate channel to be buying nitazines. And as what we think is that very few people are seeking them out on purpose, but instead they're being cut into fentanyl, which again sort of illustrates how scary they are. Usually fentanyl is the thing being cut into other substances. So if this is being cut into fentanyl, sort of illustrates its potency there. Yep. And again, like I said, based off the data there, we don't think that probably they're too widely spread, being used too widely yet, but the risks are there, which is why I definitely wanted to highlight them. All right, so I guess I'll move on then so switching gears a bit, a substance that probably folks are pretty familiar with, hallucinogens. They've been around for a very long time. There's a lot of different kinds of them. When we talk about hallucinogens, we might mean psilocybin. A lot of times we mean LSD. That's where the most data is. But we could also mean DMT, mescaline, ketamine, PCP, MDMA, salvia, K2. There's a lot of different substances out there. They introduce sensory distortions and potentially, psychological effects that can impact us. And they do present risks. There is a high, hallucinogens generally don't cause overdose, but there is a high potential for injury and safety issues due to, impaired thought processes and perceptions. And, as I said, hallucinogens, they've sort of just been they've never really been a major focus of prevention. It's not something that gets ignored, but it's a lot of times there's been more pressing issues. And in all likelihood, things like the opioid epidemic are still a more pressing issue. But a thing that I almost never see talked about is just how much hallucinogen use has actually increased over the past several years. In 2023, over 8.8 million people nationwide used hallucinogen use in the past year, at least, meaning they used it at least once. That 8.8 million means about 8% of people ages 12 and older, and that's up from 3% in 2012, which means use is more than doubled over the past 10 years. And the highest prevalence of use is among emerging adults, like so the raw numbers, that 18 to 25-year-olds, where we see sort of 6.7% of them are using regularly, but the highest growth of use is actually among adults 50 and older, meaning the total number of adults 50 and older maybe isn't a ton yet, but the growth each year has been a lot. And in 2022 and 2023, we hit all-time highs in non-LSD hallucinogen use among, you can see, adults 19 to 30, as well as 35 to 50. And probably part of the reason why this is occurring is that perceptions of great risk of harm from hallucinogens, we only have the LSD number, unfortunately, but perceptions of harm, as you can see, have been declining quite a lot, which is probably one of the reasons why use has been increasing so much. And because of these dramatic increases, again, maybe they still aren't the main priority to us because the consequences aren't as high as something like fentanyl or nitazenes have become more prevalent. But because hallucinogens almost never get talked about, at least in my experience, I really think it's important to at least call people's attention to the fact that these numbers are going up and have been going up pretty dramatically over the past 5 years, especially. And so I think it's at least worth thinking about whether we need to do more around prevention related to hallucinogens, because again, usually it isn't a priority. Now, a thing around hallucinogens, right, is that there has been some research showing that certain psychedelics may be useful in the treatment of certain behavioral health disorders. For instance, the FDA actually approved esketamine, that's one, for use in treatment-resistant depression. And sort of related to that, there's been this ongoing discussion around whether hallucinogens do have legitimate medical uses. And so I don't know enough about the science there. If the FDA approved it, I'm going to assume that was a rigorous, there's rigorous research showing that was the case. But of course, the issue is, even if something has legitimate uses, it doesn't mean that misuse can't occur, right? Like prescription opioids have legitimate uses, but obviously misuse became a very big issue. And the sort of related issue to this is that as a substance gets talked more about, as use becomes more legitimized, even if it's the medically fine use, it can lead to those perceptions of harm just dramatically decreasing. It can lead to misuse being normalized as well. And so the concern is basically, what if hallucinogens follow the same path as cannabis, where the push to legalize gets way out ahead of where the science actually is, and more people are using it without necessarily thinking through or understanding what the potential consequences are, and just the misuse rates continue to increase, and those consequences from misuse continue to go up as well. So it's, again, I think it's an issue worth keeping an eye on. So that stat I have there is the second bullet. Almost none of the states actually passed this legislation. In fact, it's only Oregon and Colorado that have fully legalized psilocybin, although I know psilocybin's also been decriminalized in DC as of a couple years ago. But the debate is continuing to go on, and even though psilocybin is the one that's legal or decriminalized, it can there's still the risk that it just sort of leads to an overall push around legitimizing hallucinogen use in all cases. And so again, it just we don't want to see the same track as we saw with cannabis. And then I have that bottom stat there that between 2017, and this sort of just illustrates that use number as well, between 2017 and 2022, law enforcement seizures of illegal psilocybin rose by nearly 350%. That's a nationwide number, but it's another illustration of sort of how hallucinogen use is growing. And because hallucinogens are a substance that has been talked about, not talked about, but at least been in the data for a number of years, the national surveys do ask about it. So I actually do have a little bit of district data here showing. So this is the past year use of hallucinogen in the district by age compared to other substances. Again, maybe the consequences of hallucinogen, aren't, well, not maybe, like, I don't think they're as high as they are as, the consequences of opioid misuse or the consequences of cocaine use. But you can see how much higher the numbers are. And so since they do have consequences, again, it's at least worth thinking through whether we want to do anything to address them. And you can see especially, that 18 to 25 number, almost 1 in 10 youth in the district we're using. So sort of just a, for your consideration, but wanted to call it out. And so
Hey, Josh, that 12 plus, that first column is 12 plus what? Like,
yeah, so the first column is actually everybody ages 12 and older. So because a lot of times we just don't have data on ages 0 to 11. So the other 3 columns are basically subsets of that. So the 12 plus is everybody, and then we have, well, here's specifically 12 to 17, here's specifically 18 to 25, and then here's everyone 26 and older.
Okay, I just wanted to make sure it wasn't just like 12 plus, like all those were younger kids. I was about to be real concerned.
Yeah, no, that includes all the adults.
Okay, good.
Yeah.
Okay.
Yeah, and we can see with the 12 to 17-year-olds, it is under 1%. But yeah, then 18 to 25, we have that big jump up.
Okay.
All right. So again, unless there's any questions about that, I'll move on to the next one. Which is tianepatine, which is a name you might not have heard of. You might have heard its street name though, gas station heroin. It is not actually an opioid itself, but it can mimic the effects of opioids, and it's not a controlled substance. It's not been approved for anything, but because it's not illegal, it can be sold a lot of times under brand names like Pegasus, Tiena, Ozaza Red. It is theoretically an antidepressant, and in some countries in Europe and Asia, it has been approved as an antidepressant, although even more recently, some of those countries have started reversing that approval because of the risks associated with it. Because the thing is, even though it's not an opioid, it can bond to opioid receptors, and so if you take it in large enough doses, it can mimic the effects of heroin. And so people, because again, it's called gas station heroin because it can just literally be bought in gas stations. It's just widely available. And, it has its own risks associated with it that, maybe, again, aren't as serious as something like nitazene, but they can, I have data on the next slide about, poison control center calls. Like it can pretty negatively harm people's health. Even though it's not federally controlled, it has, as of May, it's been banned in 9 states. Those 9 are Alabama, Florida, Georgia, Indiana, Kentucky, Michigan, Mississippi, Ohio, and Tennessee. I don't know if there's any others since then. Unfortunately, it can be hard to stay on top of states doing things. So in those states, it's not just sold in gas stations because state law enforcement would, block it. But in the states where it's not banned because there's no federal law, you can just find it available for sale. I see a question about Narcan.
Maryland recently banned it, Josh.
Oh, okay, great. Thanks, Roz.
Yeah, you might want to look. Yeah, Maryland, in our area. I didn't find any references to Virginia and DC. I looked, but Maryland recently passed legislation. I don't know if it's been fully implemented, but something for you to do in your future research, because I only saw brief reference to it. I didn't dig deep into it, but just
no,
there was
definitely
a question about the effect of Narcan.
Yeah, no, I see that one. So I have heard both answers to that, and to be honest, I don't know which one's true. I don't think it's been fully studied yet, because I have heard people say that they've administered Narcan and it reversed an overdose, and people say that it didn't. And I have not seen a published just research article on it. So I unfortunately, and I looked again before this one. So I unfortunately don't know the answer. I don't know if anyone else is familiar with tiampatine, if they've heard anything. Would please share it. But yeah, no, it is a potential concern there. So with tiampatine, we have even less data than some of the other substances. The main thing we do have is the number of calls to poison control centers over time. And you can see like these numbers are very low, but they indicate a rather dramatic increase in recent years. You can see in the 13-year period from 2000 to 2012, nationwide, there were a grand total of 11 calls to poison control centers for gas station heroin. Then in the 4-year period from 2013 to 2017, there were 207. So, 20 times more now in a 4-year period. For some reason, there's not actually data for 2018 and 19, but then in the 3-year period of 2020 to 2022, we see a tripling again to 607. And then just, I think, yesterday, so I didn't even get a chance to update the slide, I saw that in 2023, so just now for a single year, there were 391, which indicates, right, that the calls are going up. They're low numbers, and again, we don't have data on other sort of indicators, but since they're going up, it does indicate it's at least an indication that use is going up. And the problem is, right, since it's in the outside of the states where it's specifically banned, it is just a legal substance, so people, they're not getting their substances seized because they just legally purchased it. I mean, and some people may actually be purchasing it, for what they think is a legitimate use. A lot of times the bottles claim that it's a dietary supplement, for instance. So there might be some people who legitimately think that they're just getting it for that. So people are just buying it. Thanks Dave for sharing that in the chat. And yeah, I think that first sentence he said, I want to really call it right. Like anytime there's an overdose, we do want to provide Narcan because we don't know, in the moment what caused the overdose. And in many cases, there is an opioid involved. So, just like with xylazine, even though opioids don't reverse the xylazine part, even though Narcan doesn't reverse, the xylazine part, it reverses the opioid part if there are opioids. So we always want to administer Narcan if there's an overdose because it doesn't hurt, right? Yeah, moving on then, I have one last substance, which is bromazolum. It's actually the one that I have the unfortunately least info of all about, but it is something we are starting to show up as well. It's a sedative, much like nitazines. It's something that was created in a lab a long time ago. In this case, it was 1976, but was again never approved for any sort of legitimate use, and for a long time people just forgot about or never knew about in the first place. But in the past couple years, it has started to show up a lot, almost all the time with fentanyl. You can see, so depending on different studies have found somewhere between 88 and 100% of the time when there's bromazolum, there's also fentanyl. So very rarely is bromazolum being used on its own. But if it is used on its own, it can be life-threatening by itself. But again, as with sort of every substance, if you start mixing it with other substances, you can potentially compound the effect, the risks involved. And bromazolum does have various just health risks as well. Can cause very dangerous changes in blood pressure, cause seizures. A lot of potential risks beyond just sort of the life-threatening ones. And the one data piece we have, again, is just sort of inconsistent data from law enforcement that mostly just shows that it's becoming more common, but we don't know exactly how much more common. But we see from 2016 to 2018, there were less than 3 law enforcement seizures per year. Again, we don't have any data for a couple of years, but then in 2020, 2022, that jumped up to over 2,000. And then in 2023, almost 3,000 seizures involved bromazole. So we don't have other data, and it's hard, but the seizure data indicates that it is showing up more, it is starting to show up in the illicit drug supply. And so it is something, again, to be keeping an eye out on. And it's the one I have the least info on. Unfortunately, it's not as talked about, but seemed worth mentioning as well. So I have this one slide. Could take a little bit more, but if folks have any questions about it or about any of them, happy to cover them. But I also want to make sure there's plenty of time for the second half of this presentation as well. So just a couple last words from me if you are thinking of any questions. The substance use landscape is always changing. There are always these novel substances that are popping up. There's been other novel substances in the past. Sometimes they do become major issues. Sometimes they end up fading away. There can also be changes, in the more common substances we see. Things like vaping data could technically be considered emerging trends if we see changes in the people vaping. So regardless of the substances, the landscape around is always changing, and we want to stay on top of that because, as I talked about, it can lead to us wanting to potentially provide different services or better serve different populations. And if we're going to do that, we need to understand the underlying causes behind the emerging trends and make sure we're following the principles of strategic planning to make sure we're addressing them. We also want to make sure, though, that at all times we're focusing on the underlying causes of substance use. We don't want to reinvent the wheel. Someone who is seeking out nitazines probably has the same reasons as someone who's seeking out any other illicit opioids. So we don't necessarily need to do anything different around, a lot of the prevention work we're doing, but we maybe do need to make some improvements around harm reduction because of just how risky that use is there. So this is why the emerging trend data is important. And as I mentioned, the earlier we address a trend, the greater the impact we can have. And that's why, even though some of these substances might never become major issues, hopefully none of them do, there's always the risk that they could. And so that's why it's important to learn about them early on, even if some of them don't really seem that concerning just yet. And so that's me. There's my contact info if you think of any questions later on that you want to send me, but I'm here if you have any questions. But otherwise, that's what I've got.
Excellent, Josh. Excellent. And as Josh mentioned, I saw this presentation at the NPN conference. Josh, I actually think it was one of the best presentations for the whole conference.
Oh, thanks.
So, because like you said, we in prevention, we need to stay on top of emerging trends for that very reason. And this information is powerful. It's still hard for me to wrap my mind around anything that could be out there that's 43 times more potent than fentanyl. I can't even imagine that anyone could survive that at all. So we definitely need to keep track of things. And in that vein, I'm really appreciative of your time and everything, and continue to hang out. I'm sure people can put questions for you in the chat, but in the interest of time, we do want to move on to the next presentation. And we're so thankful to get the more information on what's going on in DC. So we're very appreciative to our next presenter. I'm gonna let him introduce himself, who is with the DC Forensics Lab, because we want to know, based on the syringe program that they test, what's going on in the DC. And I know he'll probably share there was a study done around counterfeit pills that was released in 2022. Hopefully there's going to be some updates for that, I'm hoping, so that we can know what's going on in DC in light of these trends that were just shared. So Sneh, I'm going to give you the mic, so to speak. Please introduce yourself and share what you'd like to share about your background and who you are.
Excellent. Well, first and foremost, thank you, Ms. Parker, for giving us the invitation to present today. I very much appreciate all of the work that you all do, and at the Department of Forensic Sciences, we really pride ourselves in being an information powerhouse. I just want to put out a quick disclaimer that we are not physicians or toxicologists. We are by trade clinical chemists. And so a big part of the work that we do is kind of serving as the information powerhouse for the district, to keep ahead of, a lot of the information that Josh shared is aligns with what we see in DC. And Josh, really appreciate all of the insights that you shared from a national landscape. I'm excited to share some of our DC specific insights. Just a quick background about me. I started my work I would say in 2014. I started my career in EMS. I started off as an EMT, went on to be a paramedic. I've worked in New Jersey, North Carolina, and Kentucky as a paramedic and as a technical rescue technician, where I've responded to these calls firsthand. And I've had successful reversals and I've had unsuccessful reversals. And that's, I think, really what inspired me as I was obtaining my credentials at UNC and Duke to really maintain a focus on epidemiology as it pertains to surveillance around overdoses and what's actually going on in our communities. So with that, as I obtained that degree, I transitioned to the CDC and was able to work with a number of states on implementing innovative surveillance programs as part of a national grant opportunity through the CDC and SAMHSA, known as the Overdose Data to Action Grant. Many of you may have heard of it, and DC receives about $3 million in funding every year, and we get a small subset of that funding to try and fill some data gaps in the district. So at this time, I've worked with the district for a little bit over 3 years, but I've been involved in overdose surveillance work for about a decade. So with that, and again, I just want to kind of set the stage here. Ms. Parker mentioned that this is fairly informal. So as I'm presenting these slides, please feel free to chime in and let me know if you have any questions. So just give that a second to load on your end. And we'll kind of jump in here. So the focus of today's presentation will be an overview of and I see your question in the chat, Dalia. We will be diving into some of the greater trends that we see, but I do want to set the stage here and provide a good overview of how our surveillance program works at a broad level, and then we'll get more specific into the different trends we're seeing. So with that, a couple of learning objectives. So this presentation is going to be broken up into 3 parts. One, we'll discuss that high-level overview of our surveillance program. 2, we will discuss our approaches to testing and analysis. And then 3, we will discuss some of those emerging trends and novel substances that we're observing and tracking. So just as a quick disclaimer, this work is funded by the Overdose Data to Action Grant in states, which is funded by the CDC. The information that is shared today, although it is the property of district government, any opinions are not necessarily those of the CDC or DFS. And all of this work that I'll discuss with you all today is, oops, sorry about that. All of the work we'll discuss today is part of the mayor's initiative, Live Long DC. And we do have a website with a lot of great information on there that kind of collates data from DC Health, us, DFS, DBH, OCME. And I will actually quickly link 2 quick resources for you that I think may be very, very helpful. Thank you, Ms. Parker, for that link. But I'll also share this link, which is to a dashboard that has recently been released. It is a collaborative effort. If you haven't seen it, I highly encourage you to give it a view when you have some time. It is fairly robust, but it does detail a lot of the data insights around different substances we're seeing in the district, overdose rates that we're seeing by ward, different demographics on patients or clients who present with fatal or non-fatal overdoses, and additional geographic insights in there as well. It has been over a year of work that it's taken to launch this project. We're very, very proud of it, and I think it'll be a great resource for you all to be able to get some more granular insights on what's actually happening where we all live. So with that, we'll move on. So, sorry, this is just kind of auto advancing on me. But I'll just kind of detail our analysis here. So I actually work with 2 units in the Department of Forensic Sciences. I work with the Forensic Science Laboratory and the Public Health Laboratory, and both programs have different approaches in terms of their analysis. So one of the units, the forensic chemistry unit, their primary objective is district-related casework. So they're taking in the seized evidence and running it through a series of tests to be able to identify any substances within that specific sample. We conduct untargeted testing as well as targeted testing. We have a library with over 1,000 substances in there. So based on our analysis and the chromatogram that we receive off the sample, we can match to specific hits in that library. Or if we identify an unknown, we work either independently to identify different subgroups on that compound, or we conduct an interlaboratory analysis where we share our findings with some other labs and researchers to help us identify any unknowns. And this has been really, really important in order for us to identify novel compounds as we see them in the district, and there have been a number that we've identified as first in the nation. So this is the quick slide on the overview of our testing program. So I'll start with number 1, the seized drug supply. So this is our primary operation within our surveillance program. We analyze the current drug supply through seized suspected controlled substances. These are generally in their raw form and bulk, which are drugs submitted to us from other agencies. Could be MPD, could be the Department of Justice, could be USAO. We receive these samples and release reporting on what we find in aggregated form. Number 2, we also, as part of our overdose data action grant, do drug surveillance through our syringe surveillance program, which we're discussing here today. This is where we analyze drug residue from used syringes submitted from our local needle exchange programs, and our team of chemists is able to extract any substances in those used syringes to give near real-time insights on the illicit drug supply in the district. Number 3, we have our clinical monitoring. We do perform surveillance on clinical samples. Right now, we are getting samples from local hospital emergency departments. This is a completely new program that we've started in this fiscal year, where we're partnering with emergency departments to fill a data gap on non-fatal overdoses. We have a lot of data around fatal overdoses. There's not a lot of existing data around non-fatal overdoses, kind of what are people ingesting, overdosing, and surviving on, as compared to passing away from. So we've just started this program in partnership with GW and Sibley Memorial Hospital, where they will provide us with some residual specimens post non-fatal overdose admission in their emergency department. So our laboratory, with a very wide testing panel, I believe the hospitals only test for about 10 substances. So our laboratory can really provide a broad array of what was actually detected in the system at the time of overdose. Number 4, we do receive death investigation syringes. So if there is an overdose fatality and a syringe is found on scene at the time of the death investigation, we can also process those syringes and provide those data insights. And then all of this surveillance kind of comes together, our reporting comes together to advise our partner agencies, primarily DBH, DC Health, and OCME, on the latest trends that we're seeing in real time, so they can get ahead and use their experts to communicate with the residents and advise them of what's going on at this current time. And there have been a number of health alerts that DC Health has issued with our intelligence, things corresponding to mass overdose incidents. Recently, there's been a rise in metatomedy. And so these are just some of the examples of intelligence that we'll supply so that our partner agencies can add their context and inform the wider community. Okay. And then next slide, we have kind of just extension of what I've just discussed. I won't go further into detail around the first 3 bullet points, but we do some tangential work on top of what we do for our surveillance program as part of some interlaboratory projects. So those last 3 bullets are part of those studies. We are actively monitoring fentanyl analogs in the district. This is intelligence that's shared with a wider array of partners. We share information with the CDC, SAMHSA, other states, national laboratories such as NIST, the National Institute of Standards and Technology, as well as the Center for Forensic Science Research and Education, both of which are leaders in these fields. And they kind of see us as a national model for such a surveillance program. So we do a lot of information sharing at that level, so all of us can kind of be on the same page as to what we're seeing in our independent jurisdictions, share best practices, lesson learns, and sometimes just kind of debrief together and get through the day, because this is some challenging work that we do. These are an example of some of the tests that we'll use to identify the different substances present in samples. Our chemists use color tests, pharmaceutical IDs, and microscopy as screening processes to get an idea of what may be present in the sample. And then they may use GCMS, GCFID, or FTIR. All 3 are different types of confirmatory testing. These are laboratory grade tests. There's no higher standard for confirming the presence of substances in a sample. So we very much pride ourselves in the accuracy of our information. Okay, and now on to the meat of things. So we'll start here with our syringe exchange surveillance update. Here you will see an overview of some of our details in regards to the syringe exchange program. We started this program in September 2020. To date, we've analyzed over 8,500 syringes. Just to give you an idea of the workload there, 100 syringes could take about a month to process. But with the capacity that we've developed over time and in just 4 years' time, we've consistently increased the amount of syringes we're testing every month. To the point where currently we're analyzing on average 300 syringes per month, releasing regularly monthly reports so that harm reduction organizations and interested community partners can see what's being used in real time. And certainly our objective here is to monitor for emerging psychoactive substances and provide reporting on IV drug use. And this allows us to rapidly identify threats. And as Josh had mentioned earlier, try and get ahead of the curve. Because I think one thing we don't realize is, a lot of these trends we've known for years. I think we started this program in 2020, and I think we had identified xylazine within a month of starting the program. So a lot of these trends may not be emerging. I will discuss the emerging ones, but many of these trends are things that have been identified in many years past, but then once the media gets a hold of it, then it seems like, now it's something. So our really, big goal is as soon as we identify a potential threat in the drug supply, to be able to get that to as many partners as possible so that they can, be the gatekeepers and tailor that messaging for their respective communities. Okay, so this is an overview, visual representation of the monthly count of syringes that we've analyzed over the past 13 years, or I'm sorry, past 13 months by drug class. And as you can see, there are, fluctuations in these counts. And as Josh had mentioned earlier, this is a ever-evolving landscape. There's always new things that we're detecting and or trying to identify. And just analyzing these trends really helps us identify periods of increased activities, specific drug spikes, changes in the supply, as well as, the social factors, the social determinants of health that go along with some of these changes. Also, I think a big part of the work we do is informing harm reduction. So understanding these patterns, I think in an acute sense, really helps us effectively allocate resources. So if I can say that, or if DC Health can tell me that there was a mass overdose incident at this specific cross street, and then I can collate that data with our syringe data, say, oh, okay, Family and Medical Counseling Service sent us 20 syringes from those cross streets 3 weeks ago. And I can look into that specific subset of data and say, okay, these were the most commonly identified substances on those cross streets. Then harm reduction organizations can kind of actively run with that there and provide those hotspot services that they do. So I'm very proud of this work. I think the biggest thing here is the real-time nature of this data collection. Oftentimes with any data collection, a lot of the data that you'll see shared in presentations like this is 3 years old. Even Office of the Chief Medical Examiner, their reporting is sometimes 3 to 6 months delayed. Whereas this, as you can see, some of our data on this page here is from September 2024. And this week we're working on our data from October 2024, and we'll release that this week. So it is near real time, and I think that provides some crucial information to our public health partners. This slide provides an example of the specific insights we can glean by drug class. So this one is specific to opioids. It's no surprise that the most common synthetic opioid is fentanyl. Comprises of 40% of syringes we tested in the past 13 months, while heroin is the most common non-synthetic opioid, comprising of 19% of syringes. However, we also track a wide variety of substances. So we track fentanyl analogs, such as fluorofentanyl. We track isotoniazine and other nitazene analogs. And this kind of detailed breakdown really allows us to tailor some of the public health interventions and treatment programs by addressing the specific types of drug use, the specific substances involved in those drug use, and working with our partners to identify the associated risks. And even taking it one step further in the opioids drug class, we can, provide overviews based on the specific substances that we're seeing and their isomers or their analogs. So here we break down two things in regards to fentanyl. One is the analogs that we're seeing detected most frequently associated with fentanyl, and then we're also identifying the top adulterants we're seeing in fentanyl syringes. So really what this slide is saying is that 99% of the fentanyl analogs that we're seeing is fluorofentanyl, is the predominant fentanyl analog that we're seeing. Really, we're concerned about this because really for the same reasons we're concerned about nitazines, right? It's not the sole compound that's more potent than fentanyl. There's a lot. There's orthofluorofentanyl, there's parafluorofentanyl, there's metafluorofentanyl. There's all of these, Josh had mentioned 13 different types of nitazene compounds identified, and there's more coming out every single day. So for us to be able to track these things such as fluorofentanyl or carfentanil, which you may have heard of, which is also much more potent than fentanyl, or fluorovinyl which is also much more potent than fentanyl itself, having that intelligence to be able to share with the wider community, I think this has proven to us that we actually need more investment in ongoing surveillance so that they can inform targeted harm reduction strategies if these are the things that we're actively finding in our drug supply. And then in terms of adulterants here over the past 13 months, you can see here most of these are non-controlled substances. However, they do have toxic effects when introduced and are co-used alongside with novel psychoactive substances. So you have stimulants like caffeine, depressants like xylazine, diphenhydramine. What we're finding with xylazine is that a lot of the use is not necessarily intentional. The reason why we can kind of tell this is because we're not seeing it in seized samples as much as we're seeing it in used syringes. So that kind of helps us identify some interventions in terms of how we're actually responding to the threat of xylazine. And now you have another sedative that's used in veterinary and human subjects called medetomidine that it has very similar mechanism of action to xylazine, but is also being found in conjunction with fentanyl, xylazine, heroin, fluorofentanyl, and some of the other common substances that we're seeing. There was a study done in 2021 by the CFSRE, Center for Forensic Science Research and Education, where they found that Washington, D.C. had the highest amount of toxic adulterants in their drug supply out of all 50 states and of all the major cities. So this is something that we're really concerned about. And just to put it into perspective, some of the syringes that we see, once everything is extracted and analyzed, sometimes we can identify up to 30 substances in a single syringe. So this is very scary. However, having the ability to...
You said 30 substances? One syringe. So that means one person injected that?
I can't say that. I can say there were 30 things in the syringe at some point in time. I don't know if it was one person
okay, be
in one
reusing the
time,
syringes.
or
Okay.
yeah, reusing, or multiple people using
Got you.
different things. I'm not, that's a gap in our data.
There was also a question, since I've interrupted you, from Talia about what is ATS. That
Oh,
might have
I'm
been on an
sorry.
earlier slide. I'm just, you know.
Yes, ATS means amphetamine type stimulant. So anything that is based off of amphetamine base structure, such as methamphetamine, is labeled as ATS. Good
A
question.
lot of good information. Any other questions since I have interrupted? Um, and I know you're going to get a little bit into this, but I know it's great to have the syringe data. But I had asked you about the counterfeit pills too, because we know, especially amongst our younger population, that it tends to be the pills that are getting smashed up and snorted, smoked, etc. So anything else you can share as you move along? I know you're going through your presentation. Just let us know about that as well. But this is excellent information in terms of what's being found in these syringes. I know you may not speculate, but you mentioned, in addition to the 30-something substances potentially in one syringe, that the amount of adulterants found in DC was like the highest in the country. Any speculation as to why that is in comparison to some other major cities? Any thoughts? Or is there any data that suggests why?
Yeah, I personally would not speculate. I think that's actually a law enforcement question, because they would have more
Okay.
insight in terms of how those things are actually getting trafficked. I would not speculate on that.
Okay. That's fair. That's fair.
Thank you.
I had to
Those are
try.
some great questions.
I had to
Those are
try
some
to
great
take
questions, but I
you
will
far out of your
follow up and
comfort
I'll,
zone. I know
yeah,
you're a data person, but I just had to try if you had any thoughts.
but I will follow up with my counterpart and see
Okay.
if they have some thoughts on that.
All right. It's kind of like what we were talking about earlier with the xylazine in Philadelphia, is because people from Puerto Rico were sent to Philadelphia for treatment. Like that's a data point of why. So some of it is not just, some of it might be something you saw on your research that might indicate. That's why I asked about the why. But that's fair enough. You can follow up with this if you can. Please continue. My apology
No,
for the
not at all.
interruption.
Love the questions. Love all questions. Okay. Next slide here. So just to get a little bit, so the prior slide I was just talking about fentanyl adulterants. This slide is talking about adulterants seen across the board in all of our syringes. So the little bar chart you see here is basically illustrating the proportions of various adulterants found in the major drug classes over the past 13 months. So this is telling you, if you look at the first bar on this chart for heroin, 551, 93% of all heroin syringes contained an adulterant. At least one adulterant, could be more. Opioids, 76% of opioid syringes were adulterated. Cocaine, 59% of cocaine syringes were adulterated, whereas ATS, or predominantly methamphetamine, about 11% of those syringes were adulterated. Methamphetamine is the one substance that we see continuing to be used on its own, predominantly. And adulteration is a really big problem, right? These are substances that are not controlled. They are toxic. They do pose significant health risks. Oftentimes, most of the time, they're exacerbating the already harmful effects of the primary substance that's being used. So here, our analysis is able to identify the most commonly adulterated substances within each drug class. And that's what you'll see in the summary portion on the right side of the slide. So again, further highlights that, the nature of street drugs is that they are unpredictable. It's important to monitor the trends because I believe it helps understand the full scope of the health risks and provides aggregate data to help tailor harm reduction strategies accordingly. In regards to xylazine, it is the second most commonly detected adulterant in needle exchange syringes. It has been consistently increasing over the past 3 years in our syringe data. Over the past 13 years, 13 months, it was detected in a quarter of the syringes we analyzed. So out of 3,000 syringes approximately that we analyzed, it was detected in about 750 syringes. This is compared to 25% over the past 13 months. In the 13 months prior to that, it comprised about 13% of syringes. And then I had mentioned medetomidine. So medetomidine is a similar drug. However, it is approved for use in humans, whereas xylazine is only approved for use in veterinary environments. Both of them are what's known as an alpha-2 adrenergic agonist. Both have been seen co-detected with fentanyl and the other top four that you see on this page here, heroin, cocaine, and methamphetamine. And it's being observed in mass overdose events. So this was, we actually, got intel from the UNC drug checking lab. They operate a laboratory essentially that provides, they do a tremendous work for the nation, tremendous service for the nation, where they will allow organizations to submit samples to them on behalf of clients for a small cost to test residual drug samples. So anybody, let's say you work, your client who get services at HIPS, if HIPS is enrolled with this lab, they could send your, baggie or cooker or, some type of paraphernalia in a little vial over to this lab, and they will provide that client with anonymized drug testing results. So they use the same type of testing that we do. However, the problem for us is there are a lot of legal issues in DC. There's a lot of red tape and bureaucracy. And although we would love to provide, such services to our clients on the ground here, there's a lot of legal pushback. And we also have a lot of constraints around funding. So all of this work that you're seeing is being funded by a relatively small amount. However, what we've identified is working together across laboratories and sharing information. We can identify these things about 5 years before they get to a point where they're unmanageable. So at this point, xylazine is kind of unmanageable, but we saw it 5 years ago in our data. And now the same thing is kind of happening with medetomidine, where we identified this in 2022, are actively looking for it in the supply, haven't seen it all. And then June 2024 comes around and Philly has a mass overdose incident. And then July 2024 comes around and then we start seeing it in 20 syringes out of our 300. And now it's August 2024 and now it's in 60 syringes. And DC Health puts out a health alert to community providers, healthcare providers, agency partners, etc. So this is really something that we are very blessed to be able to provide this information to the broader community. And I believe that, more investment in work like this will allow us to, target our interventions where Josh wants us to, really in that experimental phase. So those are some of the broad level insights. I could take 3 hours to discuss all of the different insights that we're seeing, but those are some of the high level trends. And now I will get into some of our novel and emerging trends. So as requested, the first thing I did want to talk about was a prior publication. This work was done in 2021, but the actual publication was made in 2022. This was published in Forensic Science International and aggregates findings from a counterfeit pill project we participated in as part of a broader effort. So in this study we published, we analyzed 567 pills. There were geographical diversity markers, as well as randomization involved. So we didn't have, just like the syringes, like we don't collect a lot of data because that's also a obstacle for us to efficiently run our program. So all of this data is anonymized completely. And in those 567 pills, the high level findings were that number one, about half of them were counterfeit. Of all pills, not just the counterfeit ones, the most commonly detected substance was oxycodone, and thereafter fentanyl, alprazolam, which is a synthetic benzodiazepine, hydrocodone, which is also an opioid. And then specifically with the counterfeit opioid pills, we found that fentanyl was the most commonly detected substance. In all of the benzodiazepine pills, atizolam was the most commonly detected substance. The vast majority of counterfeit pills are 30M pills. 30M pills are generally blue, and they have a distinct stamp on them that says 30M. The reason why they are so questionable is because across laboratories, once this data is aggregated, they found about 60% of 30M pills to be counterfeit. Generally, these are things that dealers will purchase a counterfeit pill press for. They'll make their own concoction. Generally, it's cheaper to go with something like fentanyl than it would be the actual substance that they're intending to supply. So they'll cut a portion of fentanyl, for example, into the parent compound. They'll make a powder out of it, and they'll purchase a counterfeit pill press to be able to press those into a 30M tablet. And what we've seen, especially more recently, what I can speak to is that there has been a push to get these pill presses off the market. However, people are actually starting to manufacture their own. So it's definitely becoming very concerning. And although we would love to, make these programs more robust and continue routine surveillance around them, unfortunately, we just, we are understaffed. We don't have a lot of funding, and there are legal concerns about even just something as simple as getting that pill to the lab, where we are navigating that situation very carefully. So while I hope that this is something that we can successfully do for our community, it may prove difficult to provide this as a direct service. However, that is something that, I am very passionate about and I'm continuing to push for. Okay, and then some of our other emerging trends. So the first bullet point here is just a quick overview of some of the recent bulletins and alerts that we put out. Most of the time, we're putting these alerts out in conjunction with other agencies, whether it's OCME or DC Homeland Security, DC Health, or DBH. And basically what we're attempting to do is provide the science behind the specific substance. So we don't really speak to clinical effects, but we will tell you, what the class of the substance is, what the mechanism of action is, what receptor it acts on, basically, as well as the DC specific data insights and any national data insights that we have access to. And then we rely on our agency partners to provide more of the clinical side of the intervention. So we've issued alerts over the past couple of years on the nitazines, on fentanyl analogs such as fluorofentanyl and carfentanil, and then most recently around metatomidine. Josh had mentioned in his portion that he is concerned about bromazolam. We also have some insight on bromazolam. Basically, we had not detected this until last year. Bromazolam is a synthetic benzodiazepine. It was initially detected in July 2023. This is what we call a novel substance, right? It's something we haven't seen before, but any novel substance, we continue to keep an eye on and track. So after July 2023, we continue to track it over a period of months. And since last year, 2023, we've seen it in approximately 100 syringes. So whereas we saw it in that single syringe in July, we've seen it in numerous syringes thereafter. And really what's the most concerning is what it's found in combination with. It's found in combination in fentanyl, xylazine, cocaine, heroin, methamphetamine, and fluorofentanyl, and all of these things could be in a single syringe. And then lastly, emerging trends, something we're continuing to keep an eye on, is another fentanyl analog known as fluorovalerylfentanyl. We first observed this in April 2024, and since then it has been detected in 5 additional syringes in April and May. However, we have not seen it since, but we are continuing to keep an eye on it. And that is all I have. So in conclusion, if you all have any questions or would like me to go back to any of the previous slides to answer any questions or provide some more detail, I'm more than happy to do so. And certainly if there's anyone interested in receiving some of our reporting, we do have to go through a vetting process for any new recipients, but I'm more than happy to facilitate that if this sort of data is something that you're interested in. I do see a hand up.
Yes, I will definitely get to Ambrose's real quick. Also, Talia asked in the chat, in your findings, did you say that 60% of the counterfeit pills had fentanyl in them? And also, were you able to see how much fentanyl?
So, Dalia, that's a great question. We're actually not currently quantifying the amounts just because this is surveillance, and quantification is a very, very involved method. It could take hours for a single sample. So currently we're just doing qualitative identification. I can tell you the specific percentage that was found in that publication. If you give me a second, I will drop it in the chat. In the meantime, please feel free to let me know if you have other questions.
Okay, and so while you're looking that up, you're going to drop it in the chat. Thank you. In the interest of time, Ambrose, I saw your hand first, and then Dr. Nora Green-Lang will follow you. But go ahead, Ambrose.
Thank you. Doctor, can you give us a sense of what is the difference between the fluorofentanyl, the regular fentanyl, the valerofentanyl? Is it the chemical composition? Is it the potency? What are the differences, and how many different types? I mean, we know about carfentanil, but some of these newer types, how are you distinguishing them between regular fentanyl? And then I have a question about the drug you mentioned that seems to, in your opinion, are you seeing, I forget how it's pronounced, but it begins with an M, in terms of xylazine. Do you feel that drug is slowly going to replace xylazine, because xylazine is a tranquilizer used for animals, whereas this can be used for humans?
Yeah, great questions. So for the first one, I will say all of the above, right? They're different in terms of potency, they're different in terms of chemical structure. Basically, the distinguishing factor is how they're synthesizing each substance, right? So even for fentanyl, primarily there's three different ways to synthesize just regular old fentanyl. However, cartels, and a lot of the kind of research side, pharmaceuticals, they have easy access to this information. So they can very easily look up synthesis routes and figure out cheaper and cheaper and cheaper ways to synthesize the same thing or something very similar. So a lot of the fentanyl analogs and even nitazines, the reason why they're making them is because they can just put a little pinch in and you will get the same clinical effect. Of course, the problem with this is that there's an increased potency. However, the people pushing these substances, they see it as an opportunity to cut their costs, make more profit. So I could not give you a specific number for the different types of fentanyl or the different types of nitazines. There are many. There are many.
And do you think that they're experimenting with the population? I mean, I can't imagine somebody drive into DC and just drop off a bag that has some of these newer types of fentanyl and just waiting to see what happens. I mean, it's how is this being introduced into the district and actually location? Where is it being introduced? Are you finding the correlation in terms of locations in your research? Is there a correlation of where you find syringes when you test the syringes, or is it just syringes are found, they're put in a bag, and they come to your testing site? How is that done?
Yes. So good questions there. In terms of trafficking, it's, if you look at the high intensity drug trafficking areas, it's the pipeline is really like New York through DC. There's also kind of like an 81 corridor. There are many routes, right? Like some of this is coming across the border, some of this is getting mailed in, some of this is raw purchases from China, operating in clandestine labs, synthesizing these things in like a little shack in some random part of the country, and then getting peddled. So it is coming in from multiple routes. And I think to the original question, it is very much you can sell the same thing for a tenth of the cost. Right? So like that is why. There was some speculation, this is not my opinion, but there was some speculation that, as people were overdosing from fentanyl, that's why they started to introduce colored fentanyl, so people could at least, like cartels introducing colored fentanyl, so that at least people could identify if, this colored fentanyl was pressed into a pill. Oh, why is this purple fleck in this pill? There's some speculation around that. I am not particularly suited to, identify the different routes in which they're actually entering. Again, I would say that probably the best people to answer that question is the DEA. So I'm happy to get some more intel on that and share with the wider group similarly. But to answer your latter question about, I actually think you have two additional questions. One is like, where are we getting these things from? So we partner with 4 harm reduction organizations in the district. We partner with Us Helping Us, Bread for the City, Family Medical and Counseling, and HIPS. All four of them operate independently, different geographical areas. Some of them have mobile syringe exchanges where, they'll put up a van on, a specific cross street and operate mobily. So we really do get a lot of geographic diversity. All of our data is pretty much from every single ward, every zip code in DC.
And the last question I asked was about the xylazine substitute.
Yeah, so I won't speculate. All I can say is that right now we're seeing them both in conjunction with fentanyl, fluorofentanyl, heroin, cocaine, and methamphetamine.
And is the I don't know how to pronounce it. How do you pronounce the
Medetomidine.
Medetomidine?
Yes.
Okay, I got it on the first try. Okay, so medetomidine, are you seeing increased presence of medetomidine?
Yes.
And is that something that could substitute for xylazine because of the fact that xylazine is a tranquilizer used for animals?
Absolutely, it could. It has the same mechanism of action. It's like more similar than Advil and Tylenol, if that gives you a reference point,
Yep.
right? But what I'm saying is we're not really seeing medetomidine like overtake it. We're seeing xylazine and medetomidine together in the same thing.
Oh my God.
Yeah. Okay.
All right, thank
Want to
you.
make sure that was clear.
All right, thank you.
Sure.
Hi, this is for both you and
Go ahead.
Josh. Can you hear me?
Yes,
Yeah,
we
go
can.
ahead, Nora.
Okay, I'm sorry. So
Uh-huh.
this is for both you guys. But maybe can you pronounce your name first? I'm sorry.
It's Snay.
Snay. Okay, Snay. So Josh and Snay. So I'm more on the prevention side. So one of the things, Josh, that you really spoke about is about the perception of harm, the lack of perception of harm. That part of this is that we're not seeing people no longer feel a sense of harm with some of these substances. So over time, I know the YRBS looks at that trend too, especially among younger people. Because with all of these various synthetic drugs that constantly will change its strength and all, what do you think on our side as prevention specialists and, community individuals that care about this, what can we do about this? Because it's going to be 10 trillion times different drugs out there. I mean, we have to get to the root cause correct. And also, what can we do? What can we do? What can we do now? What can we do? Keep going. What can we do? What can we do? The one thing I know that DC never had was this kind of sharing of data and dashboards. So there was never, it was always, you guys are great analysts and everything like that. But the people on the streets never really had this or had access to it. So I think that that's one correction that has been made in this crisis for sure. And the sharing of information. So that puts us in a better driver's seat, but it doesn't tell us where to go and how to get there. And we have these different mechanisms now, but we have to make sure they are all connected in that, the wheel, thing. So any suggestions? I hope that's not too crazy, but any suggestions from your perspective? I would like Josh's perspective first, because, that broader trend, and then now here in the district. From you, Shan.
Yeah, I mean, that is the $1 million question, what can be done. And I do think, it depends, what substance we're talking about and sometimes what population. I mean, one thing, I don't have the district data, but I know that nationally, something that we've been seeing over the past 10 years, but that really escalated during COVID, was just the declining number of people that were being reached by prevention. So like when you look at the national numbers, the number of people who participated in a prevention program outside of school, or who saw a prevention message, or who talked with their parent, when we talk about youth, talked with their parents about, tobacco, alcohol, or other drugs. Again, this is just the national. I don't know for sure about the district, but nationally, all those numbers went down. They have been going down before COVID. They went way down during COVID, and they haven't come back up yet. So, I mean, one thing is we can just try to do is just get back to where we used to be in terms of, and again, I don't know the district numbers, so I don't know if this is something that's showing up in the district too. But again, at least nationally, it's just getting people involved with seeing prevention messages again, and getting contacted by prevention, because I think a lot of people just haven't been. And again, correlation does not equal causation, obviously, but it's a correlating thing we've seen is those perceptions of harm for all the substances we do track, which aren't the novel ones, it's the more common ones, but like every perception that we see like tracked in NISDA has been going down. Even things like heroin, cocaine, methamphetamine, saying nothing of hallucinogens, like everyone's perceptions of harm of substances across the board has been going down. So I think like I said, one thing we can be doing really is just making sure people are actually seeing prevention in the first place. I think the better data sharing is an important thing. And I think at the end of the day, like no matter what substance we're talking about, or even if we're just you talk about like traditional alcohol misuse, there does need to be a better focus on just addressing the social determinants of health. Like there is more and more research showing that. I know like that sort of gets beyond sometimes the definition of traditional prevention, but there's like research, for instance, showing that being enrolled in health insurance is a protective factor against substance misuse. So just like the more we can do to address those like underlying socioeconomic factors, I think will have an impact on all forms of substance misuse. So just trying to expand that, just get traditional prevention expanded again. Those sort of the generic, broadly speaking, the things off the top of my head.
Thank you. Snead, can you kind of, on your perspective, what you would see, would like to see, rather?
I mean, I think those are two really good points. Messaging is very important. Cross collaboration between agencies is really important. I think many of you have maybe prior experiences with district government, and I think we're doing a tremendous job actually, like just with respect to that dashboard and the amount of work and cross collaboration that went into it for 6 agencies to sit at the same table and agree to share data and put a project like that together is something I'm personally very proud of. I think in terms of doing more, I think communities need to start pushing the envelope, looking at other states, seeing what's working, advocating for legislative changes that have proven effective in different states. I won't talk about the specific ones. I mean, a lot of these analyses are readily available, but DC won't allow them. So I do think, it is a lot up to our community members to actually push for, specific legislative changes that make that reduce stigma and make programs such as our surveillance program something that is acceptable. I also think it's really surprising because I give a lot of presentations and I never see any youth at the table. That saddens me a little bit. I do think youth need to be not just receivers of this information. I think they need to very much be involved in the actual change that's occurring. Because if you're just passively receiving this information, you're not as invested in it. But if you're, serving on a committee or a board, and, this is also a model that's proven in very many different areas, such as education, getting students on school boards makes a big difference in terms of the educations that students receive in those jurisdictions. So I do think that's very important. And for us specifically, we are targeting innovative surveillance. That's our thing. That's my job, is to start filling data gaps within the district, such as those around non-fatal overdoses, or counterfeit pills or just random drug submissions. People want to submit paraphernalia or cookers, to start, understanding the broader scope so that legislation can be introduced to address those areas that Josh mentioned before, the social demographics.
Oh, thank you. And I agree with, and I'm glad, Roz had put up as people were coming on our, YPLC as we, really recruit young people to be a part of the work, to be trained in the work that we do in prevention as well. And I know we're having this during the day, so, but we actually will be meeting with our young people, next week in 2 schools, one, over in, Ward 8, a middle school, and then, I guess shares the border between 5 and 7, a high school. So in addition to our regular group of young people that we work with directly. So I do agree that having young people in conversations and actually, and this is what our prevention centers do. So shout out to all of them, and our DFCs do this on a regular and consistent basis. But I think people don't quite understand prevention science as a science, and then also what we do specifically here as a prevention center, which is one of the unique things around the country, because it's only a few in the country that actually do prevention the level of what we do. So, but I just needed to know what you think we can be doing right now, and I think we are on that track, but I guess more messaging will be coming out too. But specifically with these different novel drugs, as you say, substances, how we really need to approach those particular conversations too.
Yeah, I mean, it is very nuanced, and even with, scheduling, it's such a difficult decision to make. People attribute the rise of medetomidine to scheduling xylazine. So
Right.
we also have to reflect on our current approach to legislation and if it's
Do
actually
you
working.
do you think that having safe use, this is your personal opinion, not district, safe use centers, because that is a harm reduction approach that has shown proven effectiveness. But we know that stigma is the huge barrier, and also who's going to pay for it. So are you, as a scientist, believing that, not believing, but knowing knowledgeably that that is an effective tool on
So
addressing substance
what I
misuse?
will say there is, when I had mentioned earlier, we need to look at other states and seeing what they're doing, and other countries, and see what they're doing to effectively respond. That was one of the things that I was indicating.
Okay, because I know Canada has a huge safe use, and theirs is very effective, very, very effective, and they have the data to show it. All right. Well, thank you.
My pleasure.
That's all for me, Ross.
Okay, excellent questions as always. From a dynamic duo, Ambrose and Nora Lane. Excellent questions, excellent questions. All excellent questions. We really appreciate everyone's feedback also in the chat, and you all hanging out with us. We are at our time, but if there's any additional questions,
Yes, it is.
okay, go ahead, Brother
One
Travis. Go
more.
ahead. This is good
First of
information.
all,
Go ahead.
first of all, let me humbly apologize for having to step away. I had an urgent situation, but what I heard was awesome. Great questions by the dynamic duo, as you called them. What I'm asking for now, to be able to see if you can share the PowerPoint that you did, as well as Josh. Great job, guys. Awesome job. And I had to step away for a minute, but it's only one me. So again, is it possible for me to have that email to me? I put my information in the chat.
Absolutely, I'd be happy to.
Yeah,
And
it's
can you remind?
Travis Dredd Hughes, but it should be Travis.Hughes. I introduced myself through the chat earlier. Do you see it? If not, I put it in there again.
Oh yeah, I see it. And
Okay,
also
okay.
you're with DBH.
I'm with DBH. Yes,
Oh,
I
okay.
am.
Oh,
Yeah,
Community
Travis,
engagement.
Travis is, that's
absolutely.
right. He covers all 8 wards for DBH. He is the man on boots on the ground.
No,
Oh,
I
wow,
and I help if you guys, if I can be of any kind of service to you guys, don't hesitate to contact me, and I will do the best I can to connect you with the source that you need if I'm not the source. So again, it's great working with the Ward 7 and 8 prevention team. They're an awesome group, as well as Ambrose. These guys they're really powerful in what they do. So I want to thank you all for this presentation, and I look forward to the PowerPoint. Thank you very much to both of you. Awesome.
Thank you. Yeah, I'll definitely send it to you. And yeah, I'll also send the same thing as did Roz. I'll send the slides to you as well. So if you want to send them out to just everyone or whoever, if just so you have them.
Fantastic.
Yep, do that too. Yep.
Also, I'll just reiterate real quick, we do have monthly reporting, so if anyone's interested in that, Ms. Parker, would you be willing to just serve as like a point of contact if people have interest and want to
Sure.
provide?
No, I was gonna ask both. I was gonna ask both the speakers if you would either send your presentations or anything else that you want me to get out to the group. I'll send it out to everybody, and everyone who registered is going to get a link to this recording, and I'm also going to send you the AI notes as well. So you're going to probably get more information than you want, but I'm just going to send it
Not
out to
me.
everybody.
Come on with it, Roz.
It's the
Great job.
easiest way.
Thank you.
I'm a detailed person. So, and I'm loving this AI. This AI thing is I'm not too much AI because I don't want to replace people, but this notes thing is huge. It's a game changer because it really does capture common themes and it does summarizes it well. I'll give that. Some of the other AI I'm not the big fan of, but that's another conversation for a different time. But we're also going to do the recording as well, so you'll have access to that. And anything else, Snai, so if you want to send out the links to your newsletter, or feel free to drop it in the chat because people will have access to the chat as well. I'm gonna make sure everybody has access to everything.
So just real quick clarification there, Ms. Parker. If I did provide my email in the chat, so anyone is welcome to reach out if they want to be added to the reporting
Okay.
list. It is a law
You have to
enforcement
reach out to you to
sensitive.
sign up for the newsletter.
It's not a newsletter. It's a law enforcement sensitive for official use only document that gets sent out on a monthly basis. So I have to get that vetted by our general
Gotcha.
counsel prior to getting people on.
Oh, okay.
Yeah.
Got you. Misunderstood. Okay. Thank you for that clarification.
Well, you know what, Roz, I just have to say, because you have these two great individuals on, thank you so much for, I just never really I read what you said, but I just didn't conceive that would be actually this level of information on the Live Long DC kind of level summit. So thank you, gentlemen. Thank you so much. I just wish we had CEUs because this is the kind of conversation that requires that. It's just really high level and low level as well and specific. Just amazing. Thank you.
Well,
Thank you.
here's what I'll say to that. If you guys invite me back, I can work with our hospital association, BCHA, to get CEUs for something like this.
Oh, okay. See, I didn't know that. Okay, there it is. Because as I explained to Nora's comment on that, I know how tedious it can be for people that don't have those connections to get it. It's not a simple thing. So thank you for sharing that. We will definitely why don't we do this? Why don't we plan on maybe, because there's always going to be emerging trends, if the two of you would be willing to come back in the spring, we can maybe do an update of where we are.
Would love that.
Yeah,
Also,
I
this
think
is a great group, so thank you all for your questions. And I actually had fun today presenting.
Yeah, that'd be
Oh, that's
awesome if you
good.
come.
Would love
Got you
to.
out the lab for a minute, huh?
And honestly, even if I don't know who's privy to this group, but there's a lot of work groups that I'm a part of. I join when I can. So if there's even just like 10 minutes of questions or a quick update that you'd like me to provide, I'm more than happy. Like, if you want to send me a calendar invite, jump in if I can.
Oh,
Well,
great.
Snee, can
ahead.
I just say something? I noticed that that trend going down is the same trend that we see across with the fatalities and everything like that. And it seems like it's still trending that way. I know that was the one question I forgot to ask. Do you see that trend going in that direction? Is there something happening in the supplies? Is something that it's trending downward, or that messaging is actually starting to happen a little bit more now that you said we need more data touch? Josh said more touch points, right?
Yeah.
So it's interesting.
It is interesting. I think what is really working is not one thing, right? It's kind of what you just noticed, where it's like, wow, there is actually this collation of data. Like, people are working together. But the thing is, in government, it takes a long time to like get something new integrated. So whereas, we may have all had all of the pieces to do this 4 years ago, there's, you have to navigate all of the red tape to actually bring something like that to fruition. And I think what's happening now, especially, big credit goes to the CDC, because they are investing millions in funding, and I hope it stays across all 50 states for the same kind of work. And even an innovative surveillance model like ours, before us, no one did this kind of syringe surveillance program. They're taking that and using it as a national model, say, hey, states, you want to do something like this? Here's, a couple $100,000. So I think that entire picture of surveillance, prevention, treatment, education, recovery is becoming more robust. And even the offerings at the harm reduction centers, I mean, it's just incredible what they're doing. So I think there are a lot of pieces that kind of come together, and, Narcan definitely has a lot to do with it too. So it's not just the one, like a one piece that I could attribute that to. I just see it as a lot of the pieces of the puzzle kind of figuring it out, working together. I think there's a lot more that we can and need to do. So I'm not saying that we're perfect by any means, but I do see it as, a lot of the arms of the government actually working together efficiently on this problem.
Wonderful. Josh, do you have any idea, or what you see as a trend going down too?
Yeah, I mean, I think I agree with everything you're saying. I don't think that there's really just a singular reason. Now I will also say that, right, like, there was a very dramatic increase during and after COVID. So to some extent, like, the less positive outlook would also be we're just sort of getting back to where we were before the pandemic. Hopefully, though, we'll continue to decline even from there. And because I do think there's a lot of positive work going on, and at minimum we have gotten back down, which generally, if you go back, to data all the way from like the late 90s regarding, opioid overdoses, at least, it doesn't usually go down. So definitely a positive, that I think it's worth, but yeah, is it such a high number that sort of needed to go down? And yeah, I think sort of a lot of different causes. It's hard to attribute any individual like thing to say that's the one.
Thank you.
Okay. Any other last minute questions or comments? Check the chat real quick. Yes, definitely appreciate the quality of the presentations. We try to do things that are innovative and so you all helped us accomplish that today. And definitely appreciate all the time and energy you put in pulling the information together for us. And if we could, I think it would be well received to do this again in the spring. We can figure out whether that would be April or May. We can work that out on your schedules, and certainly we'll be in touch before then. And if there are no other closing comments, questions, or concerns, or if my staff wants to add anything, or any other prevention center, or anybody else want to add anything that they're seeing from their own experiences? Anything else to share with the group? Okay, fair enough. Well, thank you all for your time. And thank you to the presenters. And I will, once I receive everything, I will send everything out from today, including the recording, chat, and the AI summary and the presentations. So it will all be coming soon.
Thank you so much for the
Yeah,
opportunity.
yeah,
Thank you to
Thank you.
everybody.
Thank you.
yeah. Thank you. Great. This
Okay.
has
Thank
been
you.
fantastic.
Everyone. Have a great one. Be safe.
Enjoy.